sir, you're experiencing bronchiectasis mainly of using this hypertonic saline, then other conditions, and then we can move to other questions.
Yes, so yes, definitely nebulized hypertonic saline is another evidence-based pharmacological therapy to assist people with bronchiectasis bring out sputum easier. But I would say that the wealth of evidence is in cystic fibrosis. So there is more data
Mm-hmm.
uh, for use in cystic fibrosis. Also, though there is some data in non-cystic fibrosis also, but the wealth of data is in cystic fibrosis. It also stems from the fact that the quality of mucus in patients of cystic fibrosis is slightly different from that in non-cystic fibrosis patients, bronchiectasis. So in
Mm-hmm.
India, we see a lot of non-cystic fibrosis bronchiectasis. We have a very very small subset of CF bronchiectasis. So we do not use nebulized hypertonic saline as often as we use the OPEP devices. That is the genuine answer which I have. But
Mm-hmm.
we take a trial in patients who have difficulty in expectorating sputum despite all these OPEP devices. But the only word of caution I have when we use nebulized hypertonic saline is the fact that it can lead to bronchospasm. So, in fact,
Okay.
the recommendations also say that if at all you are giving nebulized hypertonic saline, there are two things. We try to give a bronchodilator first and then give the nebulized hypertonic saline. And not every patient can tolerate nebulized hypertonic saline when we give them. There are a lot of people who say that they have very, very troublesome bronchospasm after this thing and they're not
Oh,
able to take it also. So, that is something we tell our patients that when we give nebulized hypertonic saline, if it is very, very troublesome, you please stop it. So that is about use of nebulized hypertonic saline in bronchiectasis, more evidence in CF. The
okay.
second thing you had asked me was induction of sputum. Yes. So that is
Correct.
something we use. That is definitely we use nebulized hypertonic saline as an adjunct when a person is not able to bring out sputum.
Mm-hmm.
So we use more often 3% because it is easily available. But
Mm-hmm.
3% versus 7%, 7% has definitely more efficacy than 3% nebulous
Mm-hmm.
hypertonic saline. Earlier, 7% was not available, but for the last couple of years, Cipla has got the 7% also. So now we have access to both of them. So 7% might be slightly better than 3%, both in induction of sputum and in its ability to thin the mucus and get the mucus out.
Sure, sir. Sir, since we are talking about bronchiectasis and you also mentioned about the World Bronchiectasis Day, some of the, usually those bronchiectasis, as Dr. Rajadhar sir also mentioned, is highly prevalent. But there are probably some gaps where probably it is underdiagnosed. So, your opinion and views on that, what could be those probable reason and how it could be improved?
Correct. So, as you rightly said, the awareness uh, in managing bronchiectasis is still not optimal across the country. There are a lot of lacunae starting from diagnosis to
Mhm.
management. So I will talk about some of the common things. First is the basic diagnosis. So bronchiectasis is always diagnosed on a HRCT. You can suspect on an X-ray, but to confirm bronchiectasis, you need to have a good quality HRCT, and that itself is a problem. So many people in the rural areas do not have access to good quality HRCT, and you only have some X-ray which comes in. So a lot of patients, by the time we pick up bronchiectasis, by the time we first do an X-ray itself, it is pretty advanced. So you are missing a window of opportunity because unlike other diseases where you have a simple spirometry to diagnose or a simpler tool to diagnose, here the first tool to diagnose itself is a HRCT. Second
Okay.
thing is, even if once you diagnose bronchiectasis, I think this is what Professor James also has said, Dr. Raja also has said, which we also every time reiterate, is bronchiectasis is not a diagnosis. Bronchiectasis is a constellation of diseases. It is a syndrome by itself. So
Okay.
your first task when you diagnose pick up bronchiectasis is to try to get an etiology. Okay, so which is again because some of these etiologies are treatable. So you have CVIDs, you have ABPA, you have probably in the future you will have treatments for PCD, you have NTM. All of these we do diagnose in around 20 to 25% of our patients of bronchiectasis. We run a bronchiectasis clinic and we are meticulous in our etiological approach. But the
Mhm.
problem comes in the fact that the access to the tests which are required to confirm a diagnosis is again limited to a small centers,
Mhm.
and they're costly. So both
Mhm.
availability and affordability are a problem. So there are many
Mhm.
people who come who reach out to us, but then again they cannot afford the gamut of tests which are required. So that again is a problem. So etiological diagnosis of bronchiectasis again is a problematic thing in our country, mainly because of lack of access. I think
Mhm.
India as a country doesn't have access to good quality testing for
Yeah, diagnostic.
the mucus, the mucociliary function, the ciliary
Hmm.
motility and all. So there is, as a country, I think there is a lot of scope to improve, and I think these are the some of the barriers to diagnosis, getting the etiology, and
Great.
then taking things forward.
And sir, as Dr. Rajadhar sir also mentioned that there are certain, I mean, even the management probably is, there are certain gaps in that. So
Yes, I
any
think
final
this is,
comments on
yeah,
that? Yeah.
this is true for most of the diseases. Uh, how much are we complying to the international guidelines? So the compliance to guidelines, as Dr. Raja has said, is only to the 40 to 50%. So this is something which all of us should practice. That when we have a person with bronchiectasis, the concept of treatable traits is a very important thing. I think this is something which we should start practicing in all our patients, that identify those treatable traits, exacerbators, the particular infections which are there, Pseudomonas colonization, the mucus hypersecretaries, the eosinophilic phenotype. All of these are treatable traits which can easily be identified and targeted and treated. And of course, the complaints. It's a chronic disease. Once diagnosed with bronchiectasis, you are bronchiectatic forever. So it is very important for us to ensure that the patient remains compliant to whatever we have suggested. So as far as treatment is concerned, I think the two things I would say is that start practicing treatable traits as one of the ways to manage patients with bronchiectasis. Second is to ensure long-term compliance so that the patients remain better for a longer duration of time.
Right, sir. Thank you so much for those final comments which were really essential. And the objective of our bronchiectasis masterclass is same, sir, to spread knowledge on bronchiectasis through the experts like you. So thank you so much for this wonderful discussion. We are coming to the end of session. I would thank Dr. Chalmers sir for such a wonderful session on treatable traits. I thank Dr. Rajadhar sir for taking us through lessons learned from Embark India and telling us how characteristic of the bronchiectasis patients in India are different from West. I thank Dr. Nagarjuna Maturu sir for telling us how important it is to clear the mucus or the mucus clearance techniques, and how important to use these non-pharmacological methods also for clearing the mucus, as well as hypertonic saline also can be recommended. Then I thank our audience. I'm sure it's a great learning experience for them. I really wish all of you the wonderful World Bronchiectasis Day. I thank our audience for spending the valuable time with us. And thank you so much to all my esteemed faculty members. We are signing off now. Thank you so much.